All right, moving on to subdural hematomas. For your exams, it's important to know that a subdural hematoma occurs when blood collects between the dura mater, the outer layer of the meninges, and the arachnoid mater, which is the middle layer of the meninges. Another high-yield fact you have to know is that, unlike epidural hematomas, the bleeding source is usually the bridging veins that connect the cerebral venous sinuses to the superficial veins of the skull. Now, the bridging veins are very vulnerable to rapid acceleration or deceleration, so they are easily damaged in car crashes. It's also high yield to remember that when there's brain atrophy and shrinkage, like in chronic alcohol users or the elderly, the bridging veins get stretched out. So even minor head trauma, like walking into a door, can lead to a subdural hematoma in these individuals. Oftentimes, individuals don't even remember the traumatic event, so it's important to always consider a subdural hematoma, especially in elderly individuals with neurological symptoms. If a subdural hematoma is detected in an infant or young child, it could be due to non-accidental trauma or child abuse. Infants and children have large heads with relatively small brains, so vigorously shaking a young child can cause a subdural hematoma, as well as other signs of non-accidental trauma like retinal hemorrhages on fundoscopy. Okay, because the source of the bleeding is venous, the hematoma usually grows slower than epidural hematomas caused by arterial bleeding. Also, since the blood isn't restricted by sutures, it can be distributed over a larger area, so pressure doesn't build up as quickly unless the hemorrhage is very large. Because of these factors, subdural hematomas tend to be more insidious. Now, as the blood accumulates, intracranial pressure increases, causing symptoms like worsening headaches, unsteady gait, nausea or vomiting, confusion, visual problems, cognitive impairment, slurred speech, seizures, dizziness, and hemiparesis that can be ipsilateral or contralateral. A subdural hematoma is considered acute if symptoms develop within 2 days of a head trauma, subacute if they develop between 2 days and 2 weeks of a head trauma, and chronic if they develop 2 weeks or more after a head trauma. Just like with epidural hematomas, if a subdural hematoma grows large enough, it can lead to brain herniation and coma or death. Now, a brain CT is usually diagnostic and classically shows a concave, crescent-shaped density that crosses the suture lines, and that's extremely high yield. And the density on the brain CT helps determine the age of the hematoma. Acute subdural hematomas are hyperdense, while chronic subdural hematomas are hypodense. Subacute subdural hematomas appear isodense, meaning they blend in with the adjacent brain parenchyma, making them easy to miss. Also, a midline shift can also be seen on CT. The morbidity and mortality of subdural hematomas are high because they can develop more insidiously and are therefore harder to detect in the early stages. Similar to epidural hematomas, the mainstay of treatment is prompt surgical hematoma evacuation. Sometimes, stable individuals with acute small hematomas can be managed non-operatively as the hematoma is reabsorbed naturally. Next,